Good afternoon, everyone. It's 12 noon, so we'll get started. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which we now gather. Just a reminder to please leave your questions till the end of the presentation. We ask that you enter them in the chat, and we ask that you answer a brief survey which will be made available to you right after the presentation. This will let us know that you are present today. And finally, our speaker today is Dr. Emily McDonald, and speaking on behalf of the Division of Infectious Diseases, I'm going to ask the Chief of ID, Dr. Marcel Baer, to please introduce our speaker.
Hello, is the audio okay? Yeah. Great. It's a pleasure to introduce a talk that has been developed by both Emily McDonald and Todd Lee. Todd, unfortunately, was unable to come. Something came up and he is unable to speak, but I'd just like to take this moment to congratulate him on his promotion to full professor and to acknowledge his contribution to today's talk. Emily McDonald has agreed to give the entire talk solo. And very briefly, for those who do not know Emily, she is a clinician-scientist, internist, epidemiologist. She's an associate professor of medicine, and she did medical school fellowship and epidemiology at McGill, did postgraduate training at Sunnybrook and Harvard, and she is now the director of the Canadian Medication Appropriateness and Deprescribing Network. I understand that one of the things we're going to come out of this grand rounds with is a new appreciation that for those of us who are older and learned PCP, and then we had to learn that it's PJP, apparently PCP is cool again, and I'm looking forward to finding out how that happened so that we can all be up to date on the nomenclature. So thank you, Emily, for presenting.
Thanks, Marcel. Thanks, Nadia, for the introduction. And yeah, very excited to talk to you today about the PCP platform. It's National Truth and Reconciliation Day in Canada today. It's also the 5th anniversary of Joyce Echaquan's death and the 10th anniversary of the Truth and Reconciliation Call to Action. So I also want to take a moment and note that. And I also would just like to take a moment to remember Charles Frenette, who passed away recently. And he was my teacher and also my colleague. And I'll be thinking of him today and in the coming days, as I'm sure we all will. So in terms of my disclosures, I don't have anything to disclose from industry. For funding, I have operating funds from the CIHR and salary support from the FRQS. I'm a co-founder of Wiki Guidelines and a clinical trialist, and I design and conduct investigator-initiated trials. So today we'll do an overview of PCP, just to remind us all of the burden, the epidemiology, talk a little bit about how to diagnose PCP, and then I'm going to introduce the platform to you and talk about some of the different domains. I also think it will be interesting to spend just a couple slides talking about our primary outcome, which is a novel type of primary outcome. So PCP is one of the most common opportunistic infections, and it's still a neglected disease. So some reports say there's maybe 400 or over 500,000 cases a year. It's got a high mortality. So if we take a look at kind of the top 5 listed below here, invasive fungal infections, you can see that pneumocystis is tied with candidiasis. We might think that candidiasis is more common. They're equally common, and they both have a high mortality. And then they're, the top leader on the list here is Cryptococcus. So a very common opportunistic infection, one that, if you're working in the ER on respirology or infectious diseases or internal medicine, you may wonder maybe once a week or once every couple of weeks whether or not your patient has PCP. It can be a challenging diagnosis to make, and the treatment can be associated with toxicity. We're going to get into kind of the history of randomized control trials and evidence that we've accrued for this disease over the past 30 or so years, 30, 40 years. So who's affected by PCP in 2025? is different than who was affected by PCP in the 70s and the 80s and the 90s. There's certainly been an increase among people without HIV as we've come up with creative ways to suppress people's immune systems. There is prophylaxis that's recommended for patients without HIV, but only in some populations. So classically, that's hematologic patients and patients with an organ transplant. But again, we've come up with some really unique ways to immune suppress people now who have rheumatologic diseases, oncology diseases. We are harnessing the immune system in order to treat cancer nowadays. And some of the infections that occur from that are not that well known or described or reported yet. People with pulmonary disease as well have an increase in PCP. There has been a slight decline among people with HIV. That's because we detect HIV better now, and so patients are less likely to present late in their disease. We have antiretroviral therapy, and there is an established program and recommendation and guidelines for chemoprophylaxis against PCP amongst people with HIV who have low CD4 counts. So incredibly, there has been only one randomized controlled trial since the year 2000 that addressed patients with PCP. So all RCTs before 2025 involved patients with AIDS. They were predominantly young men. So about 95% of the patients in PCP RCTs are male in their 40s, and again, predominantly with AIDS. So all but the 2025 trial that was recently published, which actually looked at steroids for patients without HIV, predated modern era of critical care, modern oncology, antiretroviral therapy. And we know that today, people with PCP they range in age, risk factors. Men and women are both affected. So the median age in one study from Germany, which was a national study, showed that actually people with PCP tend to be in their 60s with an interquartile range of 50 to 75. They may have less physiological reserve, altered drug metabolism, and this is important because of the dose and the types of treatments that we use. Older adults now we know have polypharmacy, so an adult who's hospitalized on the internal medicine ward, on average, they take 10 medications now, and so you can imagine that the interactions with the treatments that we give are significant and very different than they were 40 years ago. There's a much more chance of drug-drug interactions for patients who are immune suppressed for their transplant, for example. 33% of women have PCP in PCP studies nowadays, whereas before it was shifted much more towards men. There's a greater degree of comorbidity. So again, more of a propensity for adverse drug events. You may have more kidney and liver dysfunction, especially amongst transplant patients. And we've seen that the risk factors differ. So there are a greater risk of toxicity from treatments. So our patients today who we treat for PCP are much more likely to develop renal complications, hepatic complications, cardiac complications, including ventricular tachycardia or fibrillation, so arrhythmias that can be deadly, and of course, bone marrow suppression. So again, this is from this national study that was performed in Germany that was published more recently in the Lancet Regional Health, but we can see that in general, the rate of PCP is going up, and it is going up equally amongst men and women. So these advances in critical care are significant because, when we look at the types of antibiotics and the types of treatments that we give for PCP, like TMP-SMX, Septra, trimethoprim sulfamethoxazole, whatever you want to call it, and steroids, the dose and the duration are from an era before we had non-invasive ventilation, for example. So you might have needed higher doses. You might have needed to treat people longer, conceivably. All these doses and durations come before we had lung protective ventilation, before ECMO, before early mobilization. They come from prior to HIV care, better detection in ART. And there have been significant, of course, advances in oncologic care with less competing risk of death. However, we are using doses and durations of drugs that really predate all of these, significant changes in how we manage these patients with the disease. So modern evidence is, of course, required for modern patients. We hope that randomized care will replace random care here at the MUHC and beyond as we conduct more and more randomized control trials here. And we would like to, with this platform that I'll present to you today, cure more PCP with less iatrogenesis and less harm. So I'll present to you today the PCP platform, which was funded by the CAHR. Several co-investigators who are researchers and clinicians here in this hospital were involved in the submission. It involves 30 hospitals. We are proposing 6 countries, so 5 provinces from Canada, Australia, Japan, South Africa, USA, and the UK. Japan's a very interesting country to include in this platform because one of the first domains, which I'll explain to you, many of their centers have already adopted it, but they're keen to participate in an RCT. So this is what the platform looks like. It's so far we propose 4 domains. Domain 1 is initial therapy, and I'll talk to you more about these in details, but our first branch would be studying low dose TMP-SMX versus a placebo on top of the low dose. So you'd have regular dose versus low dose TMP-SMX. A second branch would be PCP treatment alternative. So if you're not able to tolerate TMP-SMX, or if you fail that therapy, what do we give you as a next treatment option? I think you'll see that in practice, that depends on who's treating you rather than on the evidence. Domain 2 is called echino-PCP, and that's for severe disease, where we would add on echinocandin versus placebo. Domain 3 relates to the duration of steroid therapy. As I alluded to before, we give a really long duration of steroids out to day 21 in some patients. And so we're going to be looking at day 10 if we could shorten that treatment duration safely. And then finally, this 4th domain was proposed, but we didn't include it in the funding proposal. We just sort of said this is something we'd like to do in the future, and that would be related to prophylaxis, because there aren't a lot of head-to-head prophylaxis studies. Again, it might be interesting in some populations to use a lower dose of prophylaxis so that it's better tolerated. And then, of course, if it's not tolerated, what should we use next? For example, should we be giving dapsone or atovaquone? Again, that may just depend on who's seeing you and who's treating you that day. And so would really like to contribute to the evidence for that to inform our decisions. So we've been working on PCP for a number of years, and many of the fellows in respirology, infectious diseases, and internal medicine have contributed to the kind of global evidence for how we diagnose and manage PCP. So I'll present a little bit of work today by Olivier Del Corpo, by Jimmy Hutsu, from Julian Senecal, Anthony Liu, Benjamin Mappen-Kasserer, and Connor Prosty. So these are all fellows and residents who have passed through our programs who have published on these topics, which is really neat. So, I'm going to ask for all of your help because a PCP platform trial, the trickiest part of it is identifying the participants and recruiting them in a timely fashion. It's not always immediately apparent when a patient has PCP, and sometimes there's a delay to diagnosis. So we're using standard criteria to diagnose whether the patient has presumptive or definitive PCP, and either can be included in the trial. But we're going to ask you to please contact us if you think your patient has PCP, because that'll be the most helpful thing for us to get them into the trial, is to come and meet them and work with the clinical team to see if they can be included. So we have typical criteria for presumptive and definitive diagnosis of PCP. For presumptive, we say you need host factors, you need to have a clinical suspicion and radiologic criteria. Newer to the presumptive diagnosis is the use of PCR, which we do have available here, or the detection of beta-D-glucan, which we also have, but there is currently a bit of a time delay, so we may not be using that so much in our center for diagnosis. PCR, we need to remember, cannot distinguish between colonization and infection. And beta-D-glucan is also non-specific. And so, it's really going to be a discussion between the research team and the clinical team to see if this patient is right for the study. Definitive diagnosis is when you've got that clinical and radiologic criteria and you've really demonstrated pneumocystis jirovecii by microscopy using conventional or immunofluorescent staining in tissue or respiratory specimens. So that's what we would call an invasive diagnosis, as opposed to the other two, which are non-invasive diagnostic criteria. So just a little bit more about these different ways of diagnosing PCP. So if we look at beta-D-glucan, there's some really great work that's been published by Drs. Prosti and Del Corpo. Here's one study where we looked at a total of 26 articles, which was comprised of about 5,000 patients and over 1,000 PCP cases. And we took a look at beta-D-glucan and a conventional cutoff of 80 picograms per milliliter. And the overall sensitivity and specificity were 83.5% and 75.5%. So not amazing, right? Which is why maybe in practice you've not been using beta-D-glucan so much to make this diagnosis. And here it may also relate to the delay in getting the test result back. However, if you had a low pretest probability, you didn't really think the patient had PCP, and the beta-D-glucan was low, you could pretty well reliably rule out PCP. So it can be a helpful test. If you pick a much higher cutoff, so you like dichotomize, and if you go above 400, the sensitivity gets reduced, but you really increase your specificity up to about 94%, which could be super useful. So if you had a moderate pretest probability that your patient had PCP and they had a beta-D-glucan over 400, you'd have a post-test probability of 90%. And in that case, you might be able to potentially forego a bronchoscopy, for example, or an invasive sampling. So we propose to use a categorical approach with less than 80 to rule out and more than 400 to rule in. This maybe allows for a more nuanced interpretation based on your pretest probability, but you will see that in the guidelines, what's used as a cutoff is the dichotomized value of 80. So, more accurate estimates are needed, but this is what we find could be useful from the literature. So that kind of rule out test, almost like a negative B dimer, and then picking a much higher cutoff to rule in so that you don't mistakenly miss an alternative diagnosis. In terms of radiology, I want to speak about Dr. Su's work. So we did find from his study that a chest X-ray is not very helpful in the diagnosis. And you'll see here, this was at a time when we briefly converted to PJP in our papers. As Dr. Baer alluded to, there was a moment when PCP was renamed PJP, and now there's about little over half of the infectious disease community who has argued to go back to PCP. The reason the name was changed was because PCP is found in rats and PJP is found in humans, and they're genetically distinct. And so we were told we should rename it pneumocystis jirovecii because that is exclusively in humans, whereas pneumocystis carini was in rats. However, someone rightly pointed out that the word pneumocystis has a C in it, thereby giving us back our power to call it PCP. So jirovecii, but PCP. Back to radiology. If you go to your CT scan, here are some helpful hints to diagnose PCP. So increased interstitial markings, quite good. You'll note that oftentimes you may be trying to distinguish between pulmonary edema and PCP, and a lack of pleural effusions in someone whose radiology looks like pulmonary edema and you're considering PCP could indicate PCP. So lack of pleural effusions was helpful to make PCP less likely. And then if the radiologist said, I think this might be PCP, or wow, this really looks like PCP, that was in fact incredibly helpful. So these had quite high odds ratios in predicting a post-test probability of PCP. And I think what's really cool about all these papers that I'm presenting to you is these are our patients. So maybe not as cool for other centers because you might say like the external validity is not so great, but really, really good internal validity because this is all based on our patient population. So when there's a clinical suspicion of PCP, I would recommend that you get a CT scan. I think most of us do now. And then identifying patients who are at low risk might help us use some of those non-invasive testing to avoid bronchoscopy. And then higher probability patients, you could then say, I really think this person needs a more invasive testing strategy. So I know everyone is really interested in the non-invasive diagnosis of PCP. This comes up all the time in the ER now. So Anthony Liu and Matt Chang and others actually were able to get some paired Quebec specimens. And they looked within 48 hours between a nasopharyngeal swab or aspirate and a bronchoalveolar lavage assessment. And they were able to show that if your NP was positive for a PCP PCR, which is a newer test, we weren't using this 10 years ago, that had a fairly good positive predictive value, not perfect. But if your nasopharyngeal swab was negative, remember PCR is a sensitive test. If it was negative, that was excellent to rule out PCP. One thing that you might come across in the literature and that I was curious about is the concept of a nasopharyngeal aspirate, or NPA. We throw that term around. That's actually a suction device. Think about you use it for like babies. We don't do a nasopharyngeal aspirate. Really what we're doing is a nasopharyngeal swab. And so if you look at some of the literature on non-invasive PCR testing, they're actually reporting on an aspirate, right? Which is a little bit different because it goes a bit deeper than our swab. And so there isn't great data, for example, on the cutoff to use when you use a swab. And we are colonized. There are people who are colonized with PCP. We don't know the exact rate, although we have proposed a study where we take the respiratory specimens that we have, where we've tested people for flu and COVID, and we rerun those against the PCP PCR so we could see what is the colonization rate, because it's not insignificant. And so you could get a low count PCR on a swab, and that might be a false positive. Induced sputum is another modality that you could use PCR on, which is actually really good, better than the swab. So if your patient can produce sputum the same way you would do for tuberculosis, you can give them saline, you can induce a sputum in them and do a PCP PCR on that. That has really good sensitivity and specificity. So sometimes I'll do that in the emergency room if the patient is able to. And again, you're thinking about those sick patients, and there's a spectrum whether or not they can get a bronchoscopy safely, whether or not they can give an induced sputum, or whether or not all you can do is really just get the swab. And then you always have to interpret that result within the clinical picture if there's a possibility that they have another type of infection that really needs to be kept in mind, especially if the count is low. So then I want to talk to you a little bit about the PCP score, which was developed by Dr. Mappin Kasserer, who is a respirology fellow. And he found that there were certain variables that independently were associated with PCP in logistic regression and created this really nice score that you could use at the bedside. So age and sex were not predictive. You could get points if you had HIV and a low CD4 count, or if you were a solid organ transplant. That makes sense. We're glad that works out. We did find that there was a kind of J point that you could use for LDH. And I know for years, we've gone back and forth on whether or not LDH in the serum is a useful marker. In this score, it does seem to work out. These are, again, our patients. So if your LDH was more than 270, that was as good as someone having HIV and a low CD4 count or a solid organ transplant. So you'd get 2 points for that. And I remember John Kimoff always comes up and says to me, "What's the LDH?" And for years I said, "It doesn't matter, John." And now I'm sorry, John, it probably does matter. So we did find that if you had a typical pattern on chest x-ray, that did come through. I know before I said that with our radiology work, it wasn't very helpful. This was just for a few patients who had a chest x-ray, but most of them also had a CT. And so you got more points if you had a CT that was typical. Wow, if you're on prophylaxis with septra, that is excellent. So it's quite protective. If you're on prophylaxis with an alternative agent, that's pretty good, but not as good as septra. So this is your risk score. And we found that actually, if you did have access to beta-D-glucan and you used that cutoff of 80 versus 400, if you had scores less than 3 without HIV, or less than 5.5 and those with HIV, and you had a negative beta-D-glucan, you could rule out PCP with 95% certainty. So we're moving towards a way to diagnose PCP non-invasively, perhaps. Of course, there's still a role for bronchoscopy. Okay, I'm going to talk to you a little bit about our primary outcome. I hope you'll find this interesting. So we are proposing something called a win ratio, or a win odds actually, which is a hierarchical composite outcome. And this may be a new primary outcome for some people. It was for me. So I'm a student of win odds. So I'm going to try and walk us all through it together. I'm not an expert in it, but I do think that it offers some really unique advantages, especially in infectious diseases research. So we proposed a hierarchy with death being the worst. And then in order, these are least worst. So new ECMO is bad, but it's not as bad as death. New mechanical ventilation, bad, but not as bad as ECMO and not as bad as death. So this is the hierarchical composite outcome. And you can see, around the middle here, we have maybe you didn't need ECMO or mechanical ventilation, but you had a very severe treatment-related adverse event. So that could be something like needing to go on dialysis. New non-invasive ventilation, it's a marker of how sick you were, but it's not such a severe event. That would be something like BiPAP or high flow oxygen. Then you have a change in therapy. So that could be because your treatment failed or you had a non-severe adverse event, like maybe you had a rash, but it wasn't Stevens-Johnson. And then finally you have length of stay. Okay, and so now I'm going to walk you through over the next slides how we calculate what ends up being what's called the win odds as your outcome. But first, let's pause. I want to break down hierarchical composite outcomes for you. So let's go back to standard outcomes. We'll take a classic example of mortality at 30 days. We're all familiar with this outcome. That is binary, yes, no. You are either dead or alive. Advantages, it's simple. There's no arguing it. You are dead or not. It can oversimplify some of the complex clinical states that we encounter. It can certainly discard some meaningful differences. So for example, you could be alive, but on ECMO at day 30. You could be alive, but in the ICU. And that is very different than alive and home. And this outcome, mortality at 30 days, doesn't capture that. It can be underpowered. I think we've seen many studies where that's the case. And the binary outcome doesn't really capture the whole spectrum of outcomes. So these are some limitations that people have discussed. And so naturally, we've seen over the years that composite outcomes have been proposed. And of course, a classic composite outcome would be MACE. We see this in cardiology. You could see an outcome of death, myocardial infarction, or hospitalization. And so if you have any one of those outcomes, you have met the outcome. Now, as you can imagine, not all these outcomes are equal in their severity. So being hospitalized may not be as bad as a myocardial infarction requiring revascularization, and certainly they're not as bad as death, but they are treated equally, and you have the outcome if you have one of those outcomes. But they may not be equally important to patients. They might not be equally important to us, but they are treated the same. And the overall outcome in some studies could be driven by the most common component. So for example, you may have 30% of your patients who are hospitalized, maybe from a CHF exacerbation, but that might not necessarily be the most important outcome to you. For example, maybe death is more important. Sometimes it can obscure the interpretation for us, so we call it a positive trial, but when we look into the details, that positive trial was really driven by a mild outcome that was reduced, i.e. you are maybe going to pay quite a lot of money for a new drug, but perhaps it hasn't improved survival. So something to think about. Okay, now we're going to get into what some people are proposing is an option to overcome some of these limitations, which are these hierarchical outcomes. So the first example is DOOR, and that's a desirability of outcome ranking, okay? These patients are ranked on an ordinal scale. So you remember like an ordinal scale, like a very classic one would be like your pain scale or the WHO COVID-19 severity progression scale. So those are ordinal scales. But in this case, they are ranked from the most to the least desirable outcome. So again, they're ranked, they're not equal. So alive, no complications and cured, alive with mild complications, alive with severe complications, and death is that's a simple DOOR, just so you can kind of get the concept. each patient is placed on this spectrum. So again, you can better capture the spectrum of clinical benefit and harm. And then what you can do is you can calculate the probability that if you randomly selected Mr. Jones in the ER and gave Mr. Jones the intervention, what is the probability that that intervention is going to give them a more desirable outcome than the one from treatment B, which is the comparator. And that's your door probability that you end up with. So some of the advantages are that it's patient-centered. It incorporates benefit and harm in a single measure. And if you think about a lot of the composite outcomes that we have, or the ordinal outcomes we have, not all of them actually have a measure of harm, right? And so what you can do is you can put both benefit and harm in this outcome, which is really neat. And of course, I care about it because I like patient safety. It avoids this composite dilution because the outcomes are ranked by desirability. And this is where patients can weigh in. So you could speak to your patient population and say, you know, is a GI bleed worse for you, or is a stroke worse for you? As opposed to if they both appear in a composite outcome, you might be treating them equally. A patient might say, stroke is way worse to me than a GI bleed, but I think both should be captured. And so you can rank them in order of importance to the patient. And it is, and this is very exciting for the people who run trials, statistically efficient. So it does avoid this kind of binary collapse of outcomes. You may require a smaller sample size, which could be really important, for example, for PCP, which is still considered a rare disease. Okay, so now we move on to win ratio, win odds, which is what we have selected as the primary outcome for this trial. This is, again, a hierarchical outcome, but you have pairwise comparisons between groups of patients. Each pair is compared on the most clinically important outcome. Okay, so first you're going to see, I think we can all agree, what's the most clinically important outcome? Alive or dead. So you take one patient and you're going to compare them to all the other patients in the control group. So you take your intervention patient and then you look at each patient and you see, did they win? And winning here would be living. And that's at the top of your hierarchy. So if one patient survives longer, that patient wins. And then if it's equal, what we call a tie, then you move to the next outcome, which could be, for example, hospitalization. And then you tally all the wins and the losses and you create a ratio, and that's a win ratio. Now, win odds is related, but what it does is it deals with ties, and it's actually a little bit easier for us to interpret probabilistically. So it uses all the data, even if you have only patient follow-up. It preserves the hierarchy of the outcomes. Still, death is more important than hospitalization, for example. And it's actually going to give you a more intuitive interpretation. So at the end of it, you're going to be able to say a patient on treatment A, let's say your intervention or your experimental medication, they have an X% greater odds of a better outcome than a patient who's on the comparator or treatment B. And that, again, is statistically efficient. Because multiple outcomes are used and you don't just sort of lump them together indiscriminately. So this can better reflect real-world decision-making. Patients and clinicians, again, just like the door, the patient can weigh in on the hierarchy and the ranking. It's not just alive or dead. It can avoid what we talked about before, which is that misleading composite. So again, by ranking the outcomes, less important outcomes, like let's say increased length of stay by 1 day, that could happen quite a bit. It's a more frequent outcome. It doesn't actually weigh in as much because you've ranked it as the lowest, but it's still contributing information. And it is a regulatory interest. So the FDA and the EMA have encouraged exploration of door win ratio, especially, I love the term exploration. So we're exploring door and win ratio, and especially in infectious diseases, cardiology, and critical care. So here they are kind of side by side. Again, here's your door where you start with the best outcome, and then you have the second best and the third and your worst outcome. And then over here, you have 3 patients, okay? And you're going to take patient 1, and they're getting the intervention or the experimental outcome. And then you compare them to each patient in the control. So you do end up with multiple pairwise comparisons. And here you see patient 1 who got the intervention, they lost, which would mean if we're at the beginning of our ordinal outcome, that would be death. And you can see here you have wins compared to other patients or ties. If we move on, just a couple more slides on this, and then we'll get to the studies. You count your wins and losses and ties. The reference group is the experimental group. These are like kind of some key things to keep in mind. You do end up with a lot of pairwise comparisons. You use ties from people who are alive. So the first step is to see whether your patient lived or died when you're comparing between patient 1 and all the patients in the control group. And from the patients who are alive, then you move down to the next rank in the order. So, if you start with James Bond and he lived, you compare him to everyone in the control group. And so he's going to contribute to your ratio, some wins and some ties, because of course, many people in the control group will live as well. So that's a tie. And then you take those ties and you move down the next rank. Now, if James Bond dies, he contributes some losses and some ties. And ties from deaths usually aren't counted. So this is kind of, now you've got like the basic 101 for win odds. When events are more rare, of course, in a study, ties are more relevant. This accounts for ties when you do the win odds versus the win ratio, which is just wins over losses, okay? More than one is a better outcome, and it ranges from 0 to infinity. And what's really cool about the win odds is we can calculate what I think is one of our favorite things as a clinician. You can calculate an NNT, which is, of course, to me, and I think to many of us, the most interpretable outcome that you can get from a trial. And so if you have an NNT of 5, which you can calculate from a win odds, that means for every 5 people you treat with your intervention, one of them will do globally better. And you saw what our ranked outcomes were. You should show the distribution of the outcomes. So usually when you report a trial this way, there's going to be a diagram that shows how common the outcome is and which outcome we're talking about. So visually, as a researcher, you should be showing how common was length of stay as the only outcome, how common was hospitalization with an adverse event, how common was death. And so you'll sort of see like a spectrum or a band showing how common those different outcomes were, because we need to be able to see that as clinicians to interpret the importance of what's being reported. And it's important to know that worse outcomes like death or ECMO carry more weight and they matter more mathematically. So this is basically what this is representing diagrammatically. In our study for PCP, you start off with death and you see what are the wins, ties, and losses. And from the live ties, you then move down to the next rank and you look at ECMO. And then you move down to the next ties and you look at new mechanical ventilation. And so you end up with your total wins and you add half of the ties and you divide it by your total losses and you add half the ties, and that's how you end up with your win odds. Okay, so now we're going to talk a little bit about the studies, which are, I think, very clinically interesting. We know that the standard of care for PCP is TMP-SMX. Now, all major guidelines list TMP-SMX at a dose of 15 to 20 milligrams per kilogram. I don't know if anyone's ever prescribed that number of tabs to a patient who's 70 kilograms, but that is a lot of double strength septra. So you might ask, where does this dose come from? Because when I treat a UTI, I give 1 double strength twice a day, not 2 double strength 3 times a day or 4 times a day, right? So why are we using this very high dose for PCP? Well, it's because of us. It's a part of our history. And so we actually, in Canada and the CMAJ, W.T. Hughes published this study. And this became the de facto dosing for PCP. So in this study, 14 children with PCP, these patients had leukemia, received 20 milligrams per kilogram per day. And in that group, 2 of the children died. And 4 children received 4 to 7 milligrams per kilogram per day, and 2 of the children died. And if you trace back the guidelines and you go and look, what is the original reference that is used in the guidelines? At first, you see guidelines, referencing guidelines, and then you see eventually the guidelines reference this study. So they say that the dose of 20 milligrams per kilogram per day is superior to the lower dose. And in this study, the therapy was free from any significant adverse side effects. This study was not powered, in case you were wondering. So TMP-SMX, is it the right choice? Absolutely, I think so. I think if I had PCP, I would want to receive TMP-SMX. Here it is in some head-to-head trials, because there have been head-to-head trials. And you can see that on the whole, it tends to favor TMP-SMX for mortality. Quite strongly for atovaquone, I'll point out. Now, TMP-SMX has important dose-dependent side effects. And so not all patients tolerate the therapy at that dose. And so what ends up happening is they're actually getting switched off of the superior therapy onto potentially an inferior therapy simply because we've tried to push the dose so high. So you can get hypersensitivity reactions, dose-dependent drug-induced liver injury, cytopenias, hyperkalemia, which of course can lead to arrhythmia, renal failure. We certainly see this happening in our older adults who are on ACE inhibitors, ARBs, spironolactone, patients who are treated for their transplant, tacrolimus. It's more common in older adults, kidney dysfunction. There are many more drug-drug interactions nowadays than there were 40 years ago. And if we look at the evidence, that comes out quite strongly. And so you see here that overall, when it comes to adverse events, TMP-SMX does not win compared to the comparator. Okay, so it tends to favor all the comparator drugs because you do get toxicity from this treatment at that dose. And again, there's no studies that look at lower doses in the randomized control trials that are head-to-head. So we asked ourselves, is a high dose really necessary? And this is work by Guillaume Butler-Laporte, who is also a staff here now, incredible researcher. And he did a systematic review and meta-analysis, which is a few years old now. But if you look out there in the world, some people have had the same thought and they've been using lower dose septra. And remember I mentioned Japan. So Japan uses more on the order of 10 milligrams per kilogram to treat PCP. New Zealand tends to use 10 milligrams per kilogram to treat PCP. I recently learned Sweden changed their national guidelines and they now use 10 milligrams per kilogram. So, you know, some very nice people are out there doing this. The RCT has not yet been done. And so all I have to present to you is observational data. And, you know, certainly this comes with a lot of caveats, but enough evidence to suggest that an RCT would be safe to run. This is for mortality. It tends to favor the reduced dose. And for serious adverse events leading to a change in therapy, it most certainly favors the reduced dose, not surprisingly. So on the whole, we wonder and we hypothesize if you could give someone 10 milligrams per kilogram of TMP-SMX to treat their PCP, and maybe you could cure just as much and actually prevent some of these pretty serious adverse events that people are getting from the high dose. So that's essentially the RCT that we're proposing 25 years later. It's a double-blind, placebo-controlled 10 milligrams versus 15 milligrams per kilogram per day. And we went over the inclusion criteria before, but we'll allow proven or presumptive PCP, most importantly. And we have some exclusion criteria like hypersensitivity to sulfa. If you've been on prophylaxis, we think that might interact or affect whether or not a low dose works for you if you do indeed have PCP. And some other kind of classic exclusion criteria. So all patients get open label 10 milligrams per kilogram per day. It can be PO or IV. And then they are randomized to a blinded extra 5 milligrams per kilogram per day of TMP-SMX or placebo. And for oral, it's a pill. And we use single strength as the intervention medication. And for IV, the placebo is saline. Interestingly, I learned that when you make TMP-SMX in saline, it doesn't have a long stability. So actually, it has to be made at the bedside. And so nurses will not be blinded to this study if the patient is receiving IV. The patient and the doctor and everyone else will be blinded. And then for oral, everyone is blinded. Again, I said there is going to be another domain one study, which is PCP alternatives. So you would be randomized to these second-line agents. It would depend on whether or not you have severe disease. So if you have non-severe disease and you don't tolerate septra, or there's toxicity, or you have to stop from clinical failure, then we would randomize the patient to atovaquone versus clindaprimiquine. And if you had severe disease, defined again by these oxygen requirements, we would randomize to IV pentamidine versus clindaprimiquine. We also have an adjunctive treatment domain. So that will be the second domain that we spin up. We know that caspofungin inhibits cell wall synthesis by blocking beta-D-glucan. Remember that blood marker that we use to help diagnose PCP. And there's animal models and observational studies that show that there might actually be some interesting synergy between TMP-SMX and the echinocandins. And they do appear to be able to prevent PCP in immunocompromised patients. So we would randomize patients with severe disease to caspofungin, micafungin, or anadulafungin, depending on what's available, versus placebo. We have an immunomodulatory domain, which was inspired actually by a recent study of steroids for patients without HIV. We originally thought we might do steroids versus placebo, but it really does seem, I'm fairly convinced that steroids help you with PCP, whether or not you have HIV. So there was the RCT that was published in PCP in 2025 was published in Lancet Respiratory Medicine. And that study is shown here, non-HIV study by Lemial et al., which was reported as a negative study, although you have to look pretty closely to see that it passes one right here. And then when you combine all of the evidence together, HIV and non-HIV, and you apply a probabilistic approach, it looks like there's quite a high probability of any benefit of steroids, regardless of whether or not you have PCP, 99.9% probability of benefit. Granted, the non-HIV data there's not a lot of it. But to me, this study, which was almost positive for mortality at 1 month, and this study, here it is down there below, was certainly positive for a reduction in mortality at 3 months, is convincing enough that I would feel a little strange about randomizing non-HIV to steroids or no steroids. So instead, we're going to do how long? We're going to do duration. It is recommended 21 days. Again, if you go back, that's all observational data from the 90s for patients with AIDS, and we've extrapolated that. And again, a lot has changed since then in terms of how we treat respiratory infections. We use steroids in COVID, and we use steroids in community-acquired pneumonia, but it's on a much shorter order, right? 7 to 10 days. And so in patients with PCP, they're often recovered well before day 21. And so we would like to randomize these patients at day 10 to continue or stop out to day 21 for the steroids, with, again, a primary outcome with a specific hierarchical composite win odds. And we would evaluate that at day 60. And that actually came from this Lancet study that was published, where we could see that mortality tended to be better around day 30, but we hypothesized that with the advances in ECMO and intubation, maybe some patients are on a ventilator and they're maybe dying after day 30 because we are able to keep people alive quite a long time in critical care now. And so we might need a bit of a longer outcome follow-up. So we're going to do out to day 60 for this one. And then finally, this is to be developed. So if you have thoughts on it, please let us know. But many of our patient populations here at the MUHC, we don't know whether or not to give them septra for primary prophylaxis. We wonder whether we could give a lower dose. We do see a lot of our patients being prophylaxed here with atovaquone. There is some resistance to atovaquone. It's quite expensive. It tastes really yucky, and you need to eat a fatty meal to absorb it. But still, we are worried about giving people TMP-SMX as prophylaxis, even though it seems, from our work that it is the best prophylaxis. We worry about bone marrow suppression. We worry about drug-drug interactions. And so that dose also could potentially be reduced. So we would be looking at low dose versus standard dose. And then, of course, some second-line therapies for patients who can't tolerate it. And maybe even third-line therapies, just in order to start contributing some randomized evidence to this. So we're launching imminently. We received REB approval for the low TMP study, which will be the first study. So look out for that in the next month. When approved by REB, we would then go to the alternative treatments and the how long study for steroids, then adjunctive casco, and then lastly, prophylaxis. And that's all I have for you, folks. Thank you. Marcel, do you want to take this?
I don't know who's moderating. There's going to be questions in the chat, and there's going to be questions in the room. So first, looking at the room, are there any hands up? Yes, Dr. Flagel, you're either going to come here or I will simply repeat your question once. We'll let you speak to the microphone, please.
there any evidence that trimethoprim alone is effective against PCP?
The question for Zoomland, is there any evidence of trimethoprim alone?
Yes, there is a little bit of evidence, but usually you would combine it. So you wouldn't give it alone. So you could do like trimethoprim dapsone, for example.
Okay, in the chat, we have two questions. So from Dr. Arietta, what about low O2 SAT, especially with physical activity? And then secondly, why 10? Sorry.
So the low oxygen saturation with physical activity, I'm wondering if that maybe means using that as a diagnostic criteria. I'm not sure. Maybe you could, Dr. Arietta, maybe you could expand on that question.
It's
yes.
sorry, it's one of the old ways of checking it out. If you're not sure, you take the patient for a little walk if they're able to walk. O2 sat drops. It's pretty predictive of something bad. I mean, I don't know if it's very specific. I'm just wondering if it was looked at in that study.
Yeah, no, it absolutely is a way to diagnose in the criteria, even putting people on an exercise bike in the outpatient clinic. So we do accept patients inpatient and outpatient. So potentially that could be used in the outpatient clinic to make the diagnosis. Absolutely. It's really hard to get people up and walking in the emergency room where we're going to be making most of the diagnosis. But yeah, no, that is a legitimate way to see if the oxygen saturation drops. In terms of the 10 milligrams per kilogram, we chose 10 milligrams per kilogram because, first of all, as the low dose, it is commonly used in the observational data. So we wanted to go with what's been used, even if it's observational. Secondly, 10 versus 15 allows people, clinicians, to increase the dose by 5 milligrams without unblinding. Okay, so you can meet the primary outcome, whether or not you're randomized to 10 or 15, you could ask to increase the medication as the clinician. So say you're the ICU or you're the internal medicine doctor and say, I don't think this is good enough. You don't know what dose they're on, but you could say, I want it upped. And you'll meet the outcome because you'll have a change in dose because of clinical failure, perceived clinical failure. And if you're on 10, that'll bring you up to 15, and on 15, that'll bring you up to 20. 5 felt too low for us. 7.5, you start to run into it. By the way, doing this, the math is already quite complicated to add on a 5 milligram placebo to the 10 milligrams. So mathematically, it made sense. And based on the observational data, it made the most sense to us.
There's a question from Dr. LeMay who's asking, was John Kimoff right?
Dr. LeMay, John Kimoff seems to be right. Yeah, so there was we did find what's called like a J point cutoff for LDH, which off the top of my head, I think was 265. And I agree, we've gone back and forth in that over the years, but our most recent publication found that over 265 was helpful. It gave you about 2 points on the score.
But he's not right enough that it becomes PJP in honor of John.
That's correct.
Okay, it's still PCP. Makeda.
For example, if a patient is seriously ill, there's already a tendency for a lot of clinicians to say, my patient is so sick, I want Caspo in addition to Septra. So does that patient automatically go to your domain too, or do you try to negotiate with a clinician to say, wait for their turn? Like just from a trial perspective, how are you going to deal with those kinds of issues?
Yeah, it's a great question, and certainly something that we've come across in all of our trials, which is that once we hint that there might be something special and new out there, people want to use it, right? So, you know, we ran the dapto study for Staph aureus here, and we could show that off-label use of daptomycin during the trial we published on this went way up. So it's absolutely, it's a negotiation. It's academic detailing of the physicians to say, like, yes, this looks interesting, but there is a lack of data. And so we would hope that you would allow us to speak to that, to your patient, and go through the consent process and see if they would be interested in contributing their data to this important study.
I'm hearing a commentary entitled Clinical Trialists as Influencers.
Yes.
Cedric.
Hi, thanks. I learned a lot. I have a question and a request for your trial.
Okay.
So I had a patient recently with an MTHFR mutation to septra, which is very unusual. but then I couldn't find any evidence to see if it's actually clinically correlated with resistance clinically. And so you mentioned atovaquone resistance, for which the genetic testing is predictive of failure. Do you imagine an arm, or not an arm, but in your trial being able to genotype a subset of successes and failures to see if there's any relationship with septra mutations?
Yeah, I would like for us to do some biobanking, absolutely. Also, I mean, for that reason, Cedric, but I would also like to measure levels, because there are not a lot of studies with levels to help with maybe some explanatory PK/PD studies after the fact. Yeah, definitely. Oh, what was your, is that the request too? Yeah, okay.
So I'm wondering if I can ask a question. Everybody's asking about the trial itself. I thought this hierarchical composite outcome is very interesting as a concept.
Thanks, Marcel. I'm glad you liked it.
And I was wondering how you convinced the regulators about it, either prospectively or conversely. There's this field called individual patient data meta-analysis. Are you aware of anybody who's done an individual patient data intra-analysis and gone back to a trial published in the past where they have individual patient data and seen whether you have greater power or greater statistical significance when you apply it to something like a classic cardiology study from the 90s or 80s?
Yeah, thanks for that question. So first of all, regulators have caught on to this, and actually they are proposing it to trialists to explore this outcome. So regulators are caught on, and I think on board, and potentially championing this as an outcome. And if you want to look up Sean Ong's work, he has reanalyzed, for example, balance, and has shown what kind of increased statistical efficiency you can get from analyzing a trial like balance, as opposed to their primary outcome, which was mortality.
Great. Glad to hear it's been done. All right, we have about 2 minutes for everybody to scurry off to their clinics or to their next meeting. Is there anything that the Department of Medicine wants to say? So on behalf of the Department of Medicine and the Division of ID, thank you, Emily. That was fantastic. And I'm echoing the comments also in the comments in the Zoom. So thank you very much.
Thank you.